Meeting of the House Committee on Behavioral Health to order. It is Wednesday, February 17th, 2021. It is 8:01. We're 1 minute behind already. We're going to, of course, start with a roll call of members to identify who's present and how they are participating. Committee members, please remember to unmute yourself, state that you're present by video or by phone. Committee Assistant, can you call the roll, please?
Yes, Madam Chair. Representative Lively?
Present by video.
Representative Morgan?
Present by video.
Representative Reynolds?
Present by video.
Representative Salinas?
I'm here by video.
Representative Solman?
Representative Solman is present by video.
Representative Wright?
Representative Wright is here by video. Good morning.
Vice Chair Moore Green?
Good morning. Raquel Moore Green here by video. Thank you.
Vice Chair Nose?
Good morning. Vice Chair Nose here by video.
Chair Sanchez?
Present by video. Thank you, everyone. So let's see. We are going to start by just an announcement. We are carrying over House Bill 2585 to Monday, February 22nd, when we hope to have an ASL interpreter available for that bill. We are going to start today by opening a public hearing on House Bill 3046. And let me just say, Zoe, I'm going to have you read the staff summary in just a second. We have a lot of people signed up to testify for this bill. We have Dr. Joe Parks here to present a particular piece around the bill, and of course, Representative Nose, who will be his bill. But I would really like people to remember that we have, as I said, a lot of people signed up to testify on this bill. I'm going to caution you to keep your testimony tight as possible. I will put a 3-minute limit on your testimony if necessary, but even you can even go under that. That would be fabulous because we have a packed agenda today, folks. Do not expect to get out early. So can you go ahead and give us a little bit of information about the bill? Thanks.
Yes, Madam Chair, members of the committee, House Bill 3046 specifies behavioral health treatments, coordinated care organizations, group health insurance policies, or individual health benefit plans are required to provide, prohibits making behavioral health treatments subject to prior authorization except as by Oregon Health Authority rule, defines terms, prohibits limiting behavioral health coverage for treatment or pervasive or chronic behavioral health conditions to short-term or acute behavioral treatment at any level of care or placement, requires insurance to have sufficient network of providers, requires outpatient coverage of behavioral health treatment to include follow-up in-home service or outpatient services if clinically indicated, limits utilization reviews to be based solely on standard of care and clinical practices and valid evidence-based sources, requires insurer to sponsor formal education program by nonprofit clinical specialty association to educate reviewers, make education programs available to other stakeholders, provide clinical review criteria to providers and insureds at no cost, track how clinical review criteria are used in the appeals process, and assess inter-rater review reliability. Prohibits insurer from rescinding or modifying authorization after provider delivers treatment. Prohibits group health insurance policy or individual health plan from containing provision that reserves sole authority to determine eligibility of benefits coverage. And you have a -1 and -2 amendment, both on OLIS.
Sorry, my apologies. The mute button got me again. Representative Nose.
Madam Chair, do you want me to kick off, or maybe it might be better to have our guest presenter go first, because I think Dr. Parks will sort of provide I think a little bit of grounding before we get into the meat of the bill, if that's all right with you, Madam Chair.
That is fine. Dr. Parks, if you would please state your name for the record and continue your testimony.
Thank you, Madam Chair Sanchez, and thank you, members of the committee. My name is Joseph Parks. I'm the medical director for the National Council of Behavioral Health, representing over 3,000 providers of addiction treatment and mental illness nationwide. Prior to being in this position, I was with the state of Missouri in both their Department of Mental Health, operating their mental health division, and then as their Medicaid director for 3 years, operating the entire Medicaid program, which included contracting for managed care services in both general medical and behavioral. I'm a psychiatrist. I'm going to start off by talking about the Witt versus United Behavioral Health decision. This decision came out approximately a year ago. And the decision is very consistent with the terms of the legislation before you. Next slide, please. In this decision, there were 11 named plaintiffs who were certified into 3 broad classes. They alleged that they were denied the benefits of treatment for their mental illness and substance use disorder because the guidelines used for prior authorization by UBH didn't comply with insurance plan and state law. Now, this suit was brought under ERISA, which covers commercial insurance, but the terms are generalizable to Medicaid programs also for the following reasons. Next slide. The question in the suit turned around whether or not that the standards used by the UBH guidelines were appropriate for determining medical necessity. All insurance contracts usually require medical necessity, and medical necessity is almost always defined as being in accordance with the general accepted standards of medical practice. So the issue in the suit was whether or not the protocols used by United Behavioral Health were consistent with the generally accepted standards of medical practice, and that was the basis of the judge's decision. Next slide. I would say that the protocols used by UBH are very similar. They were proprietary, developed by that company. However, they're very similar in structure and nature and process to the criteria offered by either Milliman or Interqual, which are the proprietary companies whose guidelines are used by most other insurance companies. So, you know, the protocols at question at UBH are similar to what other commercial companies use. The suit was filed in 2014. There were 50,000 class members. The case was tried in 2017, and UBH was found liable and in violation by the court in 2019. Now, in determining whether or not they met the standards of care, the court had to decide what the standard of care was. And they actually stipulated the court's view of what they thought were 8 generally accepted standards of care to be applied in authorizing or considering the medical necessity of behavioral health treatments. Overall, they found that the proprietary standards used by UBH had an overemphasis on restrictiveness and moving people to a less restrictive setting, and did not focus enough on authorizing care in the most effective setting, that they were underemphasizing the effectiveness of treatment in favor of offering people a less intensive level of care. Next slide, please. They did find that there are no single source of the accepted standards of care, but the sources that should be considered are peer-reviewed studies in academic journals, consensus guidelines from professional organization, and guidelines distributed by the government, such as the CMS manual, as opposed to the proprietary guidelines broadly in use commercially at this time. Go ahead. So I'll go through the standards briefly. The first one was that effective treatment requires treatment of the underlying condition and not just the current acute symptoms. So it was inappropriate to deny care once a person was no longer suicidal without considering treatment of the underlying conditions that had led them to be suicidal. The second standard was effective treatment requires treatment of co-occurring behavioral and medical conditions. So if you initially put somebody in a treatment program for their substance abuse disorder, they were actively intoxicated, but they also had a bipolar disorder, it would be inappropriate to stop treatment until the bipolar disorder was also addressed at an adequate intensity of care. You could not treat people one condition at a time. You had to consider the person's overall condition and all conditions present that they were suffering from. Next slide. The fact that a lower level of care is less restrictive or intensive doesn't justify only paying for that level unless it is also going to be as effective. Placement in a less restrictive level is only appropriate if it'll be safe and just as effective at the higher level of care, and also in addressing the person's underlying and co-occurring conditions. So of course, a person can refuse a more intensive level of care if they are dangerous to themselves or others, but the payer must authorize the level of care that is most effective, not least restrictive, unless the lower level is just as effective and likely to be as effective. The fourth principle is if there's ambiguity, if there's not agreement on the appropriate level of care, you should err on the side of caution and give the person a higher level of care until there's agreement. Next slide. Effective treatment needs to include services not just to improve people, but also to maintain their functioning and prevent deterioration. If they need continuing treatment at a more intensive level, otherwise they would suffer more, be more symptomatic, be more impaired, then they should continue at the higher level of care. The appropriate duration of treatment has to be individualized. You can't give the same duration of treatment every time. It was actually quite common to give 2 days initial inpatient treatment or 5 days initial intensive outpatient, and they said, no, you can't make it that every foot gets the same shoe. You have to individualize the treatment and have a system that does that. Go ahead. So the court found overall that UBH was not consistent with these general accepted standards. There's an excessive emphasis on addressing acute symptoms and stabilizing crisis, and that people were being pushed to a lower level of care too rapidly. I'm missing one of my slides that must have got inadvertently hidden. The other standards on that I should mention is that you have to use a multi-dimensional assessment. You can't make decisions based solely on symptom severity and risk. You have to consider a person's resilience. You have to consider their prior response to treatment. You have to consider the nature of the engagement of the family and the community, the other supports they have, and you have to have a system that does different criteria for children than adults, that is individualized by age level. Those are the two other principles that were left off my slides. I offered some handouts that would also include the full set. I apologize for the error, so check the handouts provided to you. Next slide, please. I would say that in my role as with Department of Mental Health in Missouri, we required use of the locus and CalLocus criteria of our managed care companies back around 2010. By Medicaid, we decided to do that because we were seeing inappropriately short lengths of stay at less intensive levels. It was such that if you had 2 little girls, both 12 years old, who had attempted suicide, and one of them, it was her first suicide attempt, and she had a mother that showed up at all the treatment team meetings and had stable housing and was basically doing okay. She would get the same length of stay as another little 12-year-old girl where it was her 3rd attempt that year. Her mother had bipolar disorder and alcohol problem and was moving to different housing. But the criteria as used would give both those children the same length of stay. So we required by statute that, by our contracts, not by statute, that the companies we contracted with use the locus and CalLocus. They initially thought it would be complicated and cause more expense. We persevered and insisted they used it. After implementation, they gave us feedback. They actually found it useful as a way to have more productive discussions between their care management staff and the providers, and none of our actuarial rates changed. The cap rates did not go up. Mercer did not say they needed higher capitation or to be rebased, and they did not insist. They did not lobby your counterparts in Missouri saying that they were now being underpaid as a result of this additional requirement. We did put additional requirement that they had to authorize at least the level of care scored. So if you scored inpatient, they couldn't just give you 2 outpatient. I mean, if you scored intensive and it wasn't available, then they had to give residential still until intensive was available. That also did not raise the capitation rates. It actually resulted in the companies contracting with more intermediate levels of care. So they were able to find and develop more providers of intensive outpatient, residential, both locked and unlocked. So it gave us a more comprehensive continuum of care and actually made it a little easier not to have as many readmissions and emergency room visits. So we are in agreement with the court at the National Council. Our group of medical directors has reviewed this and issued a position statement I provided, endorsing that we believe the court was correct in their view. And my personal experience implementing this over 10 years, approximately 10 years ago in a Medicaid program in Missouri, is it is doable and it will not increase your costs. So I think the legislation you're looking at will improve the system and is a good step forward for Oregon. Happy to take questions.
Thank you so much, Dr. Parks. Any very brief and tight questions, or can we go on to Representative Nose? Okay, Representative Nose.
All right, I think I'm off mute. Chair Sanchez and members of the committee, for the record, my name is Rob Nose, and I'm the state representative for Inner Southeast Portland and a little sliver of Northeast Portland. And I'm here to give some brief opening remarks this morning in support of House Bill 3046, focusing on the -2 amendment, which is basically a whole-scale substitution of the amendment for the base bill. This bill attempts to mandate standards of and access to behavioral health care for insurance plans sold to individuals, to employer groups, and also establishes those standards for Medicaid, the Oregon Health Plan, via the care delivered by coordinated care organizations, or as we sometimes refer to them, CCOs. Now, colleagues, I think we all know that every Oregonian deserves access to affordable behavioral health care without significant barriers. And we know that there are both state and federal parity laws in place requiring that health plans provide coverage of and access to behavioral health services at parity with physical health. We have passed laws requiring parity for behavioral health with physical health in this state back in the year 2007. Those standards for Medicaid, the Oregon Health Plan, via the care delivered by coordinated. I don't think that's me. I mean, it is me, but I don't think that's me creating that echo. Okay, are we ready? Proceed? Somebody's back on mute? Okay, now, as I was saying, we also know that Oregon has a long way to go in making this a reality for behavioral health consumers, because I think most of you realize we rank 48th or 49th on a lot of national measurements related to behavioral health care, depending on where you go to look. Candidly, colleagues, the statutes that we have on the books have not really provided for parity, and that lack of parity has meant lack of access and lack of compensation for providers. I'm really glad that Dr. Parks was able to be here and give us a little bit of an overview of the Witt decision, because this bill is based a lot on that court case. House Bill 3046 is Oregon's enactment of that Witt decision based on legislation from California, which, as Dr. Parks revealed, has become model legislation nationally. House Bill 46 does this by modernizing, by updating the definition of parity and coverage for mental health and substance use disorders so that it's truly equitable to how healthcare systems and payers define physical, or as I will sometimes refer, medical surgical treatments and benefits. And as I said, it does this for individuals, it does this for group plans for employers, and it does it for Medicaid, the Oregon Health Plan. The bill also requires reporting requirements that regularly measure where disparities exist and network adequacy requirements that ensure Oregonians have access to the care they need, no matter their location or their insurance provider. People will be able to review these reports, and then we can monitor and see where gaps are. And I would argue, Madam Chair, appropriately pressure entities to do better based on information where it's obvious they're falling short, or by the same token, over time, be able to measure improvement. Now, as you all review the bill and the -2 amendment, please pay attention to the definitions that insurance plans and regulators and the Oregon Health Authority will need to zero in on to achieve the point of the bill. Pay attention to the definition of medium maximum allowable reimbursement rate. This is about how providers get paid. Pay attention to the definition of non-qualitative treatment limitation. I had to practice that, Madam Chair. This is how plans have tried to put limits on benefits and payments to providers. And here's what I think is the key part of the bill. It's a little bit of a mouthful. Each carrier that offers an individual or group health benefit in this state that provides behavioral health benefits, and each third-party administrator that administers claims for behavioral health benefits shall conduct an annual analysis of whether the processes, strategies, specific evidentiary standards, or other factors the carrier or third-party administrators use to design, determine applicability, and apply each, here we go, non-qualitative treatment limitation to behavioral health benefits within each classification of benefits are comparable to and are applied no more stringently than the processes, strategies, specific evidentiary standards, or other factors the carrier or third-party administrators use to design, determine applicability, and apply each non-qualitative treatment limitation to medical surgical benefits within the corresponding classification of benefits. Now, Madam Chair, that is a mouthful of lawyerly phrasing, but this is parity and application process, and it will be required of our coordinated care organizations as well. For too long, behavioral health issues have been stigmatized, and those who suffer them have been seen as, well, frankly, weak. We are more likely to share medical challenges with cancer or broken bones than we are about mental health challenges like depression, even when they are common and occur for many of us. With House Bill 3046, Oregon can ensure that following a behavioral health crisis, children and adults will receive the support necessary. We can ensure that treatment and utilization management decisions will be based on treating underlying conditions, not just acute symptoms. And because the way we drafted this bill will touch a lot of Oregonians as we are changing and improving the care standards for those with employer-based or commercial insurance and those on the Oregon Health Plan at the same time. The standard of care in behavioral health will improve for a lot of people. Thank you, Chair Sanchez and members of the committee, for listening to my testimony, and for Dr. Parks for being here. I urge support of this bill with the amendments, and I'm happy to take questions, though you've got a lot of folks testifying, and so maybe we could do that at another time or at the end.
Thank you, Representative Meadows. Very thorough. A brief question, if it is hopefully brief, Representative Moore Green.
Thank you, Chair Sanchez, and thank you, Dr. Parks and Rep. Nose, for bringing this forward to us. I think my question is for Dr. Parks, and certainly can be a follow-up. Within the Missouri model that you referenced this morning, have you seen, or has that state seen, a decrease in the emergency room visits and the relapsing? I guess what I'm looking for is, what's the proof of the pudding? How metrically has it worked? Thank you.
Yes, we have seen a decrease in ER visits and hospital days. It is difficult to attribute it to this one change alone. There were many other program and enhancements, developments that coincided with the Cal Locus implementation. In particular, an extensive health home care management and care coordination initiative. So I can say the numbers got better, but I can't say that it was solely and entirely due to requirement of the Locus and Cal Locus.
Thank you, Dr. Parks. Really appreciate your testimony and you being here to explain some of these things to us. So again, we are going to start with testimony. I will remind folks we need to keep this very, very short, if at all possible.
Chair Sanchez, I do have a quick question. I'm under attendees, though, so you probably didn't see my hand go up.
I did not. It's way down at the bottom then.
Yeah. Just real quick. So thank you, Dr. Parks, Rep. Nose. I think this bill is long overdue, sorely needed. My question, though, is how, maybe you can take me through how the bill either attracts or provides for robust provider networks so that we ensure that those are there in place as we start to roll this out.
I would argue, Madam Chair, Representative Salinas, I would argue that it's a little bit indirect, and though there may be folks that testify to reveal this, but I would argue that if we make it easier to get treatment and to be reimbursed properly for the treatment that providers are offered, over time, we will draw more people into this profession because people will see that the work is valued, it is compensated better, and then it'll create a pressure on the industry, the health insurance industry, to hire more people to provide the care that we're demanding parity for. But it doesn't do it automatically, I would argue. I mean, like it is a way to change the care expectations and then in turn draw the insurance industry and providers into the system in a better way.
Madam Chair, I believe I could answer the representative's question in a little more detail if I may.
Certainly.
So if you pass the law, then they will have to, and use the locus and cal locus, it comes up with a level of care. And you have to give at least that level of care or higher. They will still be very motivated to reduce their hospital days above all else because those are the most expensive. There are some people now that score as needing intensive outpatient or needing residential, but your network is not, they haven't contracted enough capacity in the network. And currently their method is to put somebody into regular outpatient, a med visit, a couple therapy visits. They will have to continue these people at inpatient until the intermediate level of care is available. It forces them to pay longer inpatient days rather than drop somebody to a lower level than they actually need. The second way is an inadequate network is actually one form of a non-quantitative limitation of treatment. If I'm not willing to contract at rates that attract adequate numbers, such that I have to, such that there's much longer waiting lists for one type of specialty provider than another, that could be enforced as a non-quantitative limitation of treatment. For instance, it's been common in some surveys that insurers will offer higher rates to primary care for an office visit than they will for behavioral health. And if you're seeing better access to primary care than behavioral health because you've set your rates lower, if you're using Medicare as a benchmark, say, that would be evidence of a non-quantitative limitation of treatment. But you will have to give your Medicaid agency and your insurance agency the political support and the manpower staff to enforce these contracts. You know, they will need staff to go and check on the plans, and they'll need your support to hold compliance. But those mechanisms are in the bill, given that they have the support and manpower to implement it.
Thank you. Okay, again, we have a very long list of folks who want to testify. I will remind you, we are going to actually limit your testimony as much as possible. But if you can even be more brief, that would be helpful. Because I will unfortunately have to cut it off given how many other bills we have on the schedule today. Chris Boneff.
Chair Sanchez, members of the committee, have just 3 quick slides to share, and we'll be able to be brief. I'm Chris Boneff. I'm the Executive Director of the Oregon Chapter of the National Alliance of Mental Illness and a constituent of Representative Nose's, a proud constituent. I just want to quickly say what this really is all about. In the -2 amendments, the material that's in the original bill and that Dr. Parks alluded to is in Section 5 for Medicaid and Section 6 covering commercial insurance. So that's embodied. The remainder of those sections, the rest of it is really around the data metrics and reporting and pay parity that drive the network adequacy. Why is this a huge problem? And this is what we've done over and over and over again and continue to do. We have people who have needs. We don't serve a good chunk of them. Those who do get services are underserved and don't get to the treatments that are helpful to drive their underlying cause. And so what you have is 5% of the people who have some need get the full benefit of any care. And that's why you see tremendous burdens elsewhere in public systems and private systems, and why this issue is ubiquitous. We just are not being served year after year after year after year, and that's why we're a tremendous burden across the board. Next slide, please. Some of this, so taking off my advocacy outrage hat, there's a reason we don't do this well is we haven't bothered to try for very long. And so this tells you, I mean, it was only in 2005 that in our state, we bothered to even try Federal level was 2008, but it really didn't roll out in 2013. We didn't have benefits in insurance products, individual insurance, until the Affordable Care Act, and behavioral health finally, both for mental health and substance use disorders, became an essential benefit. And we didn't require it in Medicaid federally until 2016. When you lay this out, we've really only bothered to try doing this for 5 years. So there's a reason we don't do it well. There's a reason this legislation is necessary. There's a reason that systematic, regular data reporting has to occur every year so that we know that we're pushing the system forward, the payment system and the delivery system. Last slide, please. And then I just want to show, we talk about the burden of services. We don't talk about the burden of cost. For us to access care, particularly on the Medicaid side, we just disappear and we have terrible outcomes. And it's rare that we're able to go out of network and pay out of pocket just by nature of what disposable income we have available to us. So Section 5 addresses that and puts those expectations on Medicaid level of care. It costs us as Oregonians a lot more money on the commercial side because we can't get to the care we need. And because of inadequate provider panels, we will pay out of pocket to get to the care we need. And you see this gigantic disparity between behavioral health out-of-network utilization and utilization of primary care and other medical surgical specialties. Those are real dollars coming out of our pockets trying to get the medically necessary care that we deserve that meets the generally accepted standards of care that Dr. Parks alluded to. And I will just conclude my comments with that. This is what this legislation is getting at, and this is what it's all about. Thank you.
Thank you, Chris. Frank King.
Yes, good morning. I'm calling in from my mobile studio at a rest area on Interstate 5. Good morning, Madam Toastmaster, honored guest. Oh, wrong meeting. Sorry. I'm Frank King, a suicide prevention speaker and a comedian. I live in Springfield, Oregon. And with apologies to Charles Dickens, it was the best of care was the worst of care. Best of care for my physical maladies, worst of care for my mental maladies. On the physical side, I've had 2 aortic valve replacements, a double bypass, a heart attack, and 3 stents. On the mental side, I live with major depressive disorder and chronic suicidal ideation. 2012, I was working as a comedian on a cruise ship. You guys remember those, I imagine. Had a bout of angina. My suspicion was that the aortic valve replacement I'd gotten in 95 was failing. It was a human tissue valve. It had miles on it when I got it, and after 17 years, it needed replacing. When I got home, I called my primary care doc, who worked me in immediately. Took one, listened to my heart, deemed it was life-threatening, sent me directly to the hospital, did not pass go, did not collect $200 for testing. At the hospital, I had an echocardiogram. It was declared that I had a life-threatening condition, immediately scheduled for surgery. Shortly thereafter, I had an aortic valve replacement, and they tossed in a double bypass for good measure because it was 2 for Tuesday. Spoiler alert, I survived that surgery. Fast forward, late fall 2016. As I said up front, I live with 2 mental illnesses, major depressive disorder, which is relatively common, and chronic suicidal ideation, also a life-threatening condition, which is a bit rarer. For me and others in my tribe, the option of suicide is always on the menu as a solution for problems large and small. Now, up until 2016, I've been self-medicating my depression and thoughts of suicide with some over-the-counter supplements and holding my own, and then came the November election. I began to slide into a deep depression, couldn't pull myself out of a literal death spiral. Coincidentally, I had an appointment with a primary care doc and decided it was time to ask him for some help with this life-threatening condition. Often those of us with mental health issues are forced to advocate for ourselves to get the care we need. I've never had to do that once with my physical conditions. You show up at the hospital with heart attack symptoms, nobody gives a shippa about HIPAA. You get care right away. I told him I'd like him to prescribe antidepressants. He asked me why. It was the first time he had inquired about my mental health in 4 years that I had been coming to see him, even though he was supposed to ask me the 2 gateway questions and 7 follow-up questions on the mental health inventory, the PHQ-9 questionnaire, every time I saw him. I told him of my depression, suicidality, and if something didn't change soon, I was going to kill myself. He had a PA call in a prescription for an antidepressant, Wellbutrin, patted me on the head, sent me on my way. No follow-up appointment, no referral to a therapist, not even the standard question asked of anyone who is having suicidal thoughts. Do you have a plan? As a suicide prevention speaker and trainer and mental health advocate, I find his bedside manner borderline malpractice. I stopped by my local Walgreens because it was the first time I had taken Wellbutrin. I was told I had to have a consult with the pharmacist. You guys know the drill. Paul took one look at the bottle. What was in it? Became immediately concerned. How was I doing? Was I struggling? Was I seeing a therapist? 2 weeks later, My wife noticed an improvement in my mental state. 3 weeks, I had a thought I hadn't had since high school. I like my life. My second thought was, why'd I wait so long to begin taking the antidepressants? My third thought was, on the antidepressants, I didn't care who was in the White House.
I'm sorry, Mr. King. I'm going to have to cut you off there. We're behind time, and we talked about that 3-minute thing.
I'm done.
All right. Fabulous. Thank you. Carol Dickey. Carol Dickey, are you there?
I am here. Good morning, Chair Sanchez and members of the Behavioral Health Committee. I am Carol Dickey. I live in Multnomah County, and as a member of NAMI, Oregon, I'm here today in support of House Bill 3046. My partner and I have 5 extraordinary children, all adopted through the foster care system, and not once in my wildest imaginings did I ever think that one day I would be on the phone with the hotline asking to send one back. But that is what happened last spring after the residential treatment center where my 11-year-old son had been kept at the state hospital level of care for 38 months, decided to discharge him to home. They provided 2 months' notice with no opportunity for step down. They invited us to find our own intensive service aftercare providers and let us know in writing that if we couldn't comply with the terms of his discharge, they would report us for abandonment. In the excruciating agony of looking for options, about a month before his planned discharge, we received from the RTC the results of our son's most recent testing. It was a diagnosis of autism. We received it by mail, and we were left to resource services and supports ourselves. My son expresses his behavioral health challenges in physical aggression, most often directed at younger or smaller children. And at the time of his planned discharge, the longest he had gone without physical restraints or seclusion in more than 3 years was 14 days. With 3 of our children being either younger or smaller, we had been saying clearly for over a year that we would not be able to maintain safety in our home with him there. There was no place for our little boy to go. So after exhausting alternatives, I made a desperate call to the hotline to ask DHS for help, and I hired an attorney. Upon his discharge last July, my son was placed in a BRS foster home. And then 3.5 weeks later, that placement disrupted because, you see, the other children in the home were younger and smaller, and the family couldn't maintain safety with our child there. There was no place for our little boy to go. Later that day, he moved into a hotel, and that is where he stayed for the next 2 months. In October, benefiting from a significantly expedited process, my son moved into a professionally run DD foster home. My son is in a good place, and our family is thriving because we could hire an attorney. In this state, where system of care values are at the fore, no family should have to hire an attorney to have their voice heard. There must be services in place for all who need them, when they need them, for as long as they need them, and treatment that is safe, effective, and appropriate to the unique needs of the child. Equally importantly, there has to be compassion at all levels within the behavioral health system, because isn't that what the people we love deserve? Thank you.
Thank you. Rachel Wiggins-Emery.
Hi, good morning, Chair Sanchez and committee members. My name is Rachel Wiggins-Emery, and I'm here on behalf of the Coalition of Licensed Professional Counselors and Marriage Family Therapists, also known as COPACT. COPACT has submitted testimony in support of the bill, but I wanted to use my time to walk through the provisions of the amendment, of the Dash 2 amendment, on behalf of the diverse coalition of providers and consumer advocates that have spent the last 6 months working on this issue. We have also submitted, working on this bill, not on this issue. We have also submitted a more detailed section-by-section overview of the amendment, recognizing time and the complexity of the issue. As mentioned before, the overall goal of this bill is to increase and improve access to behavioral health for Oregonians, with behavioral health encompassing both mental health treatment and substance use disorder treatments, and to improve contract terms for providers, which will draw providers into in-network panels and incentivize more people to enter and remain in the field. House Bill 3046 with the -2 amendments does so by focusing on reporting, strengthening our current mental health parity law, and aligning it with the WIT decision and network adequacy. Regarding reporting, these reporting requirements build off the Senate Bill 860 reporting requirements and the CCO audit and are intended to mirror federal law that requires all commercial plans to perform parity compliance analyses between medical and surgical and behavioral health and applies those reporting requirements to coordinated care organizations. It requires that these reports be submitted to OHA and DCBS on March 1st of every year, and that those agencies in turn report back to the relevant legislative committees by September of every year. In addition, it does require that DCBS create what is essentially a permanent RAC to review the commercial reports and make suggested updates to rule, guidance, or statute. As discussed previously, the bill also strengthens Oregon's current mental health parity law, aligning it with the WIT decision and standardizing how we treat behavioral health across both Medicaid and commercial insurance. Finally, the bill adds specific network adequacy and reimbursement parity requirements so that families and individuals can get access to the providers they need to get care, no matter where they live or who provides their insurance coverage. This includes requiring that commercial insurers have an adequate number and distribution of behavioral health provider types accepting new patients, recognizing the issue of ghost panels, where there's providers that are paneled but aren't taking new patients, able to treat the specific and specialized behavioral health needs of their enrollees, and able to timely deliver medically necessary behavioral health treatment within the geographic region of those enrollees. It also requires that the panel be diverse of providers from communities represented by their enrollees, including LGBTQIA, BIPOC, non-English speaking, etc. It requires that they use the same reimbursement methodology to set rates for behavioral health treatment providers as is used for medical and surgical treatment providers. And it requires that insurers cannot require providers to bill with specific codes or restrict reimbursement to particular codes unless based on medical necessity. And I just want to note very quickly, apologies, Chair Sanchez, that while we have begun our stakeholder outreach, we just finalized our draft amendment a couple weeks ago. We know additional conversations need to happen. We're anticipating needing amendments. We're happy to engage with folks who have questions, comments, concerns to look at other amendments, but we really want to make this a bill that works for everyone so we can increase access.
Thank you.
Thank you for the time.
Tim Clement. Again, reminder, folks, we are running low on time, so.
Thank you, Madam Chair and the committee. And I will be brief. My name is Tim Clement. I'm the Director of Legislative Development for the American Psychiatric Association. I'm going to speak specifically about the very complicated term that Representative Nose, Dr. Parks, and Rachel alluded to, those non-quantitative treatment limitations. Just to demystify what that means things like prior authorization, how insurers design and maintain their networks, step therapy, geographic restrictions, many others. The reason that this reporting is necessary is because numerous state and federal investigations over the last several years have found insurers out of compliance with those components as they regard to the federal Mental Health Parity and Addiction Equity Act. And that evidence was so compelling that between 2018 and 2013 states passed model legislation requiring reporting on these non-quantitative treatment limitations. And even so compelling that in December, Congress, an act passed and the president signed into law a federal requirement that all insurers and all group health plans in America have to perform these comparative analyses on non-quantitative treatment limitations and submit them to the relevant state or federal regulator upon request. So this legislation would just be establishing the annual reporting period for submitting those analyses that are now required by federal law. So there should be no insurer pushback on that. It's already required of them under federal law. One thing I do need to note, it seems like there was a bit of a technical drafting error in the amendment. And so we had anticipated that the language would match what was in that model legislation and what is now federal law. It does not align necessarily now with what is in federal law and in that model legislation. So it does need to be corrected by amendment. We have that language available. We can provide to the committee. But if it's not corrected, you would now be in conflict with federal law. So that does need to get cleaned up. But we think the overall purpose is very important and very needed. And I think that you'll see that insurers will not have a problem with doing that because there's been so much compelling evidence that they've been caught with their hand in the cookie jar on that. And also it's now federal law. So that's just requiring that insurers report to the state for both insurers and CCOs what is now already a federal requirement. And I will conclude with that.
Thank you very much. Let's see, we have quite a list of folks, so I'm going to actually ask some of you if you are able to provide written testimony, and maybe we'll schedule another. We have to carry this over anyway because there's too many folks here. So can I just call on J.L. Wilson, and then we're going to stop this one for now because again we are quite a bit behind, and we have several other bills on our agenda today. Go for it.
Thank you, Chair Sanchez, members of the committee. J.L. Wilson, representing the Oregon Independent Mental Health Professionals. We're a multidisciplinary trade organization of licensed clinical social workers, licensed professional counselors, and psychologists. I'll just take 1 minute of your time. We are very much in support of House Bill 3046. We came to the legislature with this information several sessions ago in 2017 with our observation that the intent of Oregon's mental health parity law was being undermined by insurer practices that apply utilization and management policies that are more restrictive to mental health outpatient procedures than medical outpatient procedures. And this was leading to bad outcomes in the system, including diminished access to mental health treatment for those who need it most, mental health patients unable to afford the care they need due to out-of-network and higher out-of-pocket costs, less overall expertise on panels, and a decrease in the number of mental health providers willing to work in-network. In fact, our survey of membership showed that at the time, over half of our members had left a panel in the past year, and another half were contemplating leaving one or more additional panels in the coming year, highlighting the issue of inadequate panels. So we went to work with Senate Bill 860, passed that. In many ways, House Bill 3046 is an extension of that work. We wholly endorse it and support the bill. Look forward to working with you to pass it. Thank you, Madam Chair.
Thank you. I'm going to call one more, Dan Cushing.
Good morning, Chair Sanchez, members of the committee. Dan Cushing here representing Coalition for a Healthy Oregon. We are very supportive of mental health pay parity, and we've always supported increasing reimbursement for behavioral health providers, very much needed. We have some people reviewing this bill in the -2 amendment, and we just had some delays due to the power outage. But from the comments we received so far, we want to work with the proponents on a couple of amendments. To the part about CCOs, just 2 issues for the record this morning. Reporting, we don't want to be duplicative, especially when we're asking providers to submit stuff to us. We don't want to detract from patient care by having them submit the same thing multiple times. And then on prior authorization, we just want to make sure that it's structured in a way that we can still deliver high value care and protect patient safety. So thank you for your time, and we look forward to making this a really successful policy.
Thank you so much. Again, I'm going to ask folks who did not get called on today, if you're on the, if you signed up to speak, we are able to receive your written testimony 24 hours afterwards here. So feel free to do that. And again, we may be speaking about this again. Clearly, we lost a day, so we're backed up with things. So I'm going to close the public hearing on House Bill 3046. And open a public hearing on House Bill 40, sorry, God, dyslexia is kicking in way early in the morning, 2469. And Zoe, can you tell us a little bit about this bill, please?
Yes, Madam Chair, members of the committee, House Bill 2469 requires state medical assistance program to provide up to 6 preventative behavioral health checkups every 12 months, regardless of medical necessity or behavioral health diagnosis. Specifies that behavioral health service shall be provided to all medical assistance recipients, regardless of their enrollment in coordinated care organization.
Thank you. Representative Stark.
Good morning, Madam Chair and members of the committee. My name is Dwayne Stark, State Representative in House District 4, Southern Oregon. Here to testify, as was just mentioned, on House Bill 2469. Appreciate you guys taking this up this morning. And pretty much the description kind of summed it up. This is a simple concept with some complex details. And I'll be the first to confess right now that the wording in the bill right now is far from complete. It was a way to move the concept forward, and there are a number of groups that are now speaking into the details of how this should look if we were to go forward with this. The concept actually originated in my world from the Honorable Barbara Smith Warner, who I think you'll hear from this morning if she was able to hang out and make it in. And the concept is fairly simple. The idea is that we want the Oregon Health Plan to provide preventative behavioral health counseling for individuals without having or being requiring them have a medical diagnosis. Okay, so here's the idea. Right now, we have we have preventative health for every other area. You can go in for an eye exam but without having eye problems. You can go in and see your primary care physician for a physical. You can have your women's health checkup. There are all these checkups that we can do without having to give someone this medical diagnosis to receive, any sort of treatment. And especially in behavioral health, if somebody wants to go in and speak with a counselor, and if they, in order for their insurance to cover that or OHP to cover that, that clinician is required to give them a medical diagnosis that can stick with them for a long, long time and can also carry a huge stigma with it. I want us to start looking upstream. I want us to start saying, hey, it is normal and okay to sit down and do a little counseling with a behavioral health counselor. That's a good thing. It's a normal thing. And that's something that we all should do every so often. And so what I'm trying to do here is open the door for that to be normalized without that diagnosis, a handful of sessions. And then once that's done, they can always at some point do an assessment and say, okay, we do need to give you a diagnosis and roll this into ongoing treatment if needed. So a lot of things going on with this, some moving parts. About 2 years ago, I met with the Oregon Health Authority, and they told me that they thought they could do this without a bill. They haven't had the opportunity. They've had a lot on their plate. They are doing some things that are similar. One thing that they're doing that is similar is a rapid engagement model that they're working on right now with the treat first model. So I met with them yesterday. They are going to get back to me soon on what they can and cannot do in this realm with or without a bill, and what a bill would clarify for them. There are also some other groups that are speaking into the process right now. You'll probably hear from this morning that are trying to help me with the wording on, exactly which clinicians, what certification criteria, is it a QMHP? Is it an LCSW? Is it, all the different credentials that could provide this. So we're working that out a little bit. We're also even the set definition of a behavioral health checkup or is it behavioral health preventative care? All that's still in the works. Hopefully it can be worked out fairly quick because there are a lot of experts who have wanted something like this for a long time, who you will hear from in just a moment. And just to wrap up this morning, I do, even though I'm not sitting on the committee, if this moves forward, I will vote on it one of these days. And so I do need to provide a potential conflict of interest for you guys on this bill. Although my wife has scaled back her practice right now so she can focus on her legislative work, my wife is a professional counselor and does provide counseling services. So should this go into place, it would affect her business, albeit very minimally.
Thank you, Representative Stark. Representative Smith-Warner.
Thank you so much. Thank you, Chair Sanchez, Vice Chairs, and members of the committee. For the record, my name is Barbara Smith-Warner. I have the honor of serving as the State Representative for House District 45, Northeast Portland, Maywood Park, and Park Rose. Thank you. I just wanted to start by thanking Representative Stark for introducing this bill and for giving me the opportunity to check in briefly in support of it. Just a couple highlights about this, and it ties in beautifully. I was watching a little bit of the bill before this about the need for parity, and as I had been thinking about what this bill is about, first and foremost, it is about parity, right? It is about, it is another way to try to equalize physical and mental health. And I can see some folks on this, including Representative Salinas, who, as I did, worked on Capitol Hill in DC years ago, where it's been 20 or more years since the federal government first started passing laws saying that there has to be parity between mental and physical health care, and there still isn't. It continues to be something that we need to work on and push forward. So first of all, it's just so important for us to continue to acknowledge that that mental health care needs are just as significant as physical health. Number two is the idea of preventative care, right? As Representative Stark mentioned, not only there's an array of health situations where you can get preventative care. Frankly, that is how we have been moving in the way we pay for care, right? Whether it's the Affordable Care Act or the Oregon Health Plan, we have been moving to structure it so we do move upstream, so that we can, if preventative care is fully paid for, right? It's an access issue, and the idea of providing folks with with mental health care, counseling in particular, as preventative care is really key. So originally, when I came up with this, and I have to credit a good friend of mine who is a counselor herself, and this is something we noodle on sometimes when we're together. We came up with when we talked about how can we get more and better access to counseling in particular. I will say that is my bias. I have a little bit of the zeal of the converted. I have finally myself recently started seeing a regular counselor and I can speak to the amazing impact it has preventatively. It really does. It is the idea of kind of having a regular outlet to work through what's going on in your head and in your life is amazing. So I very much am a zeal of the converted here. And though our original idea was 12, how about if every healthcare plan has to have 12 sessions per year? Because that way, and I would pitch with an actual counselor. So as Rep. Stark said, there's some language work that we need to get to about, because I don't want this to turn into I don't want it instead to be oh yeah, here, just fill out this form and that's your mental health checkup. We really do want this to be access. So my original proposal was 12, the idea being if you're in a crisis, you could have 2 sessions a week for 6 weeks, or otherwise, just as regular preventive care, it could be 1 a month for a year. But whatever it is, we need to do what we can to give people more access to that one-on-one mental health. In my bias on this is for counseling. And so thank you for taking this up, and I really look forward to continuing to engage and support it as we go through the process.
Thank you, Representative Smith-Warner. Rick Trelevin, sorry if I messed that up really badly.
Thank you, Chair Sanchez and members of the committee. You did a wonderful job with my name. I'm impressed. So my name's Rick Trelevin. I'm the CEO of Best Care Treatment Services out of Central Oregon. I live in Tumalo and Deschutes County. And I'm also the mental health director for Crook and Jefferson counties. I want to support this measure. I think it'll address 3 populations that we see currently in community mental health that we have trouble addressing. One is we know that children have been particularly impacted by the pandemic, and many of them are not severe cases, and many families will want to be able to have a checkup, and that will be a huge access and advantage. We also currently see many adults who actually only want to see a counselor for a brief period of time, sort out some things. But what we're required to do is go through a 2-hour assessment. There's 1 session, then another session for service planning, and then they can talk to us for 2 more sessions and be done. That's a waste of resources for everyone and blocks up access to mental health services for more severe folks. Third population is actually people with severe substance abuse or mental health disorders. They're often very ambivalent about coming into services, so having easy access without having to go through the whole challenge of the assessment and service planning, and that gives them a chance to try it out and give easier access, and we'll be able to reach out to more people. So want to support these things. I think this will be a cost-effective use of services. So thank you very much for my time.
Thank you. Chris Bonoff.
Chair Sanchez, members of the committee, I'll just be really, really brief. NAMI is supportive of this in concept. Anything that interferes with a therapeutic process prevents accurate diagnosis and any kind of treatment in counseling could provide. upfront having to have a diagnosis and the focus on that interferes with the development of the therapeutic process. So anything that can remove that barrier and really put this in a more proper sequence, we would welcome. I would also real quickly point out that if you're lucky enough to have employer-sponsored employee assistance program, some people already have access to this. There's no need for diagnosis. There's a number of visits, and you can really address short-term needs and then discern is long-term treatment necessary. I believe this should be widely available and welcome this legislation. Thank you.
Chris, your name for the record, please.
I'm sorry, Chris Bonneff with NAMI, Oregon. My apologies.
Thank you for the brevity, no problem. Carla McCafferty. Do we have Carla?
I saw her name on the list.
Yes, I'm trying to get my camera back on here, but I'll start talking. Chair Sanchez, members of the committee, for the record, my name is Carla McCafferty. I am the Executive Director of Options for Southern Oregon, and I'm here today to provide testimony in support of House Bill 2469 on behalf of the Association of Oregon Community Mental Health Programs. Through House Bill 2469, we put into practice what we already know, that good health is not limited to just physical health, but includes behavioral health as well. Intervening early and preventing mental illness and substance abuse enables children and adults to be healthy, to go to school, to work, to raise healthy families, and to productively contribute to our communities. Unlike our physical healthcare system, where preventative services are an expectation and even incentivized, when it comes to our behavioral health system, you actually need to have a diagnosable mental illness or substance use disorder to get services. We've done a lot of work in our state to promote and support the importance of overall health. We recognize that it makes good financial and personal sense to provide and participate in preventative care. It is past time to include behavioral health in this picture, from not just a treatment perspective, but from the perspective of preventing the need for treatment. The cost to the individual, to families, and to our society is too great to continue to require that people get billed before they can ask for help. Thank you.
Thank you. Zoe, do we have anyone else on the list?
I do not have anyone else.
Well, that was quite amazing then, that we have actually gotten through everyone in this list early. So I'm going to close the informational or the public hearing on House Bill 2469 and open a public hearing on House Bill 2980, peer respite centers. Zoe, can you give us a little information about the bill, please?
Yes, Madam Chair, members of the committee, House Bill 2980 directs the Oregon Health Authority to provide funding to peer-run organizations to operate peer respite centers, specifies that peer respite centers should be located in Portland metropolitan area, Southern Oregon region, and Eastern Oregon region, requires peer-run organizations to allow OHA to access peer respite centers for investigations and assessments, defines peer respite services, peer-run organizations, and peer support, allocates $2.25 million in general fund money to provide $750,000 to each peer respite center, declares emergency effective on passage.
Thank you, Zoe. Representative Cedric Hayden.
Thank you, Madam Chair. Thank you, members of the committee. The House bill before you, 2980, is
Your name for the record, please. Your name for the record, please.
Yes, sorry, Madam Chair. My name is Cedric Hayden, State Representative from House District 7. The House bill before you, 2980, is a bill that we've had prior. It's been through the House Healthcare Committee. Didn't make it all the way. I believe we had unanimous vote on that. Here is the concept, and we've got some good testimony to follow, so I'll be fairly brief. The concept is that we have a gap in our mental health system between going to a state hospital or getting held in a regular hospital on a mental health hold, and we don't have anywhere for people to have beds or a respite center. So we want to create in that gap between having to send somebody to a state hospital or having them held long-term in a regular hospital. We want an area to send these folks, and this would be called a peer respite center with peer-based folks there, people that have lived experience with it. The idea is to have the Oregon Health Plan set up 3 of these, one in Metropolitan, one in Southern Oregon, and one in Eastern Oregon. We haven't called out exactly where, but in my mind, the concept is for them, the Oregon Health Authority, to work with organizations like Cahoots in Lane County. Now, Cahoots has been functioning for a long time. They do ride-alongs, they interface with law enforcement, and they send counselors, sometimes instead of law enforcement or along with law enforcement, so that they can treat on the site for people that are about to or have gone into crisis. But what we don't have is a bed for them to go to. We don't have a short-term place for them to rest for a few nights. And so this would be like adding 6 beds per center is the concept. Now, the bill doesn't lay out this detail because we want the Oregon Health to set it up, but the concept is to add 6 beds per center where if they have a contact with somebody, they have a place to go, a pillow to sleep on, and a warm place to rest so that they keep them out of the crisis, they keep them out of the hospital. And so we have some testimony that has some lived experience with this, and I think it's just a wonderful bill, and it would fill a gap that we don't currently have in Oregon. Thank you.
Thank you, Representative Hayden. Are there any questions for the representative? Great, we will move on then. Corinna Byrons? Are you here with us? Corinna, looks like. Byrons?
Hello, can you hear me?
I can hear you now.
Oh, okay. I was going to try to do this by video, but I'm having some technical problems, so I'm feeling really weird right now. But I guess I'm not going to be able to make this video work, so I'll continue by phone. Am I doing this right?
Yes, you're doing fine. Your name for the record.
Okay. Hi, hello, Chair Sanchez and committee members. My name is Corinna Byrons. I live in Portland, Multnomah County, and I am participating in this meeting to urge you to support House Bill 2980 to establish peer respites in Oregon. Okay, so briefly, I'm excited about this bill because it would establish peer support services by peer-run organizations to fill a gap in mental health services in Oregon. I really know the value of peer support and peer-run organizations because I started to make great progress in managing my own depression and anxiety illnesses when I worked at a large peer-run mental health agency in Philadelphia, Pennsylvania. Peer-run organizations are different from other types of mental health organizations because encouragement, inspiration, and accountability for self-care were just far more compelling to me when they were modeled by my coworker peers who had overcome mental health challenges that were even beyond what I had experienced. Peer support inspires personal responsibility and self-determination in a way that therapists and doctors and social workers can't. In addition to my own personal experience with peer-run organizations, this specific peer respite model is particularly appealing to me for Oregon right now, based on my experience in a 20-year relationship with a wonderful person who has a, quote, severe mental illness, unquote. We're doing pretty well right now, but we have had a number of years that have been very rough. And a lot of that rough time, in addition to his symptoms and my symptoms were due to housing instability, because when he would be unable to just chill out after 10 o'clock when you're supposed to be quiet in an apartment, we had a hard time having staying in apartments. There was 1-2 year period where we moved 3 times, and each time it was really, we didn't know what the former landlords were going to say about us and if we were going to be able to get an apartment. So it's just incredibly stressful when people who are in extreme distress have nowhere to go. Outpatient services, they're great. But if you need something a little extra in Oregon, that's the hospital. And there are a lot of people who are just not bad enough to go to a hospital. Or if they do try to go to a hospital, they get turned away if they're not a danger to self or others. And Oregon really needs something in the middle where someone who just needs a little extra help can go and be with some people who know what it's like to hear voices, know what it's like to have paranoid delusions, and can stay with you and listen and give you tips for getting back to something a little bit more normal. So the pure respite model would do a lot to fill that gap. And so I'm a big fan of the pure respite model. It's been implemented in 14 other state systems. So this isn't just something that we pulled out of our ears and thought, this looks good. This is a successful model in 14 other state systems, and I'd really love to see it implemented here in Oregon.
Thank you. Thank you, Karina. Dwight Holton.
Good morning, Chair Sanchez, members of the committee. My name is Dwight Holton, and I am the Executive Director of Lines for Life, a nonprofit dedicated to preventing substance abuse and suicide and promoting mental wellness, and also a proud constituent of Vice Chair Nose. Lines for Life is fully supportive of this legislation to provide for pure respite centers. In part because pure respite centers are just a natural and essential part of the solution for our currently fractured and inadequate crisis intervention system. And I think this bill comes at a perfect time because as we look to the future of crisis intervention in Oregon as well as throughout the nation, we're shifting now to this 988 model. As many of you know, Chair Sanchez has been deeply involved in this. Oregon, along with the rest of the country, is going to adopt 988 as a 3-digit access to behavioral health services. So just as we have 911 for fire and medical emergency, we'll have 988 for behavioral health emergency. 988 will distribute calls to the National Suicide Prevention Lifeline, which Lines for Life and Northwest Human Solutions answer in Oregon. And what happens next is the big question, because we expect significant growth in volume. Lines for Life took about 30,000 crisis calls last year in Oregon. SAMHSA and our folks at the National Suicide Prevention Lifeline tell us we can expect more like 135 to 210 by 2024. 135 to 210,000 calls in Oregon by the year 2024, and building a system that is ready to deliver the right kind of help at the right time with the right treatment folks and the right support to people is essential. Pure respite is an essential part of that leg. We kind of envision 3 legs of the stools: the call center, a mobile response, and stabilization. And to the extent we can do peer stabilization with pure respite centers, we know that it's a healthier, often lower cost outcome, lower cost model. We see this as essential and urge the committee to adopt this and move forward.
Thank you so much. Angel. That's all the name. It's the only name I have here. Angel.
Thank you, Madam Chair. Hi, my name is Angel Prater. I'm the CEO of Aware Consulting Group and previously the executive director of Folk Time, which is in Portland, Oregon, and has been for over 33 years. I'm in favor of peer respite model, House Bill 2980, and I've been actually advocating for a peer-run respite in Oregon for nearly 2 decades. As a person with my own mental health and addiction history, I and many others would have used a peer-run respite over my 24 years in my recovery journey. Peer-run respites should be the standard, not merely an alternative. As a business professional, I find myself continually frustrated now how the money is allocated to spend on costly and often ineffective models of the dominant medical model deems as a care model. And that's not to say that I am demonizing the medical model. It's just creating more of the same models, resulting in creating more of the same poor outcomes and an excessive drain on our system. Despite the respite model, I did a cost analysis several years back. If we had one person at a respite model for 7 days, and you multiply 7 days by 52 weeks, we're looking at serving 260 people in 1 year at one respite home. An ER visit for one person for 7 days in an ER, multiplying that with 260 people, the cost is a minimum of $4,550,000, not including ambulatory calls, 911, police, etc. People use the ER as an entry point. No wonder the state historically has been in a deficit with financial deficit and poor outcomes, and ultimately people are dying. Our state and our entire country has built a broken system by other bill, obviously from what other bills and testimonies have said today. We have taught people to use the ER. We have taught them to use the ER as a way of getting respite. I'm not just talking about low-income people. I'm not just talking about people on who are houseless. I'm also talking about you. I'm talking about your family, your friends, your children, the future children of your children. Our model currently teaches them to use an ER as a way to get respite or help, and it's ineffective and very costly. I'm also talking about your doctors, your personal providers, your personal veterinarians. Doctors on average are dying by suicide 500 a year because they have no place to go. And I'll just leave you with this. It's because they're risking losing their licensure. This is a broken system. And I'll fast forward. Instead of risk, I'm sorry, I have ADD. So people are dying because they'd rather die than lose their license or their livelihood. And that is a really big issue. Respites can fill this gap for a confidential, safe place for people to go. And it should be the standard, and not looking at this as a cost savings, but a life savings and a cost reallocation. I don't believe $2 million is enough, but I'm ready to start with 3 respite centers in Oregon so that then we can make this have more respite centers than we have ER doors, so that we can make it the standard and save some lives. Thank you very much. I appreciate your time.
Thank you. Kevin Fitz.
Yeah, hi, this is Kevin Fitz. I'm a volunteer with the Oregon Mental Health Consumers Association. Good morning, Representative Sanchez and Behavioral Health Committee. I just wanted to, first of all, I want to thank everybody who came forward to support peer respite. Some of you may or may not know, in 1999, I was working on a grant project with Governor Kitzhaber, and he sent me out to New Hampshire to look at what was the first peer respite model, as far as we know, developed in the nation, that developed out there in New Hampshire. So we've been trying, like Angel is right, we've been trying to bring peer respite to the consciousness of the behavioral health leadership and the legislature for the last 20 years, particularly. I also want to echo what Representative Hayden said. This bill, almost for verbatim, the text was in HB 2831 and passed Representative Salinas' House Healthcare Committee in 2019. One of the things that I wanted to make sure that you understood is Representative Greenlick, one of the last things that he tasked Steve Allen, who administers the Oregon Health Authority's Behavioral Health Administration, was how many councils, work groups, and committees do you have? And the last count, that was somewhere between 42 and 44. Why is that essential here? Because you folks may know me because I testified last week about HB 2313 and the Alcohol and Drug Policy Commission. But one of the things I want to let you know is that in 2020, the Oregon Behavioral Health Directors, Oregon Consumer Advisory Council, created by this legislature almost a decade ago, recommended unanimously that Pat Allen and Steve Allen put peer respite on their buy package for legislative session 2021. In a parallel process, Governor Brown kicked off in October 2019 a Behavioral Health Advisory Council, and two of those work groups, two of those committees on that three-part council all recommended peer respite as a buy in legislative session 2021. So I think it's in trying to understand what this council does, what that council does, what the recommendations were. Those people believe in those processes and believe in peer respite as a great value to the system. One thing that I want to say particularly, that this, and Representative Hayden talked about it, if we have 18, if we're serving 6 or 7 people in these 3 peer respites, 21 people a day may have some intermediate voluntary safe place to go if they don't meet criteria for being locked in an acute psychiatric crisis ward. Why is that essential? A woman shared earlier, I have been in and out of psychiatric acute care wards 12 times in the last 10, 12 years. But I've also waited on a gurney for 14 more times saying, Mr. Fitz, I'm sorry, but you do not meet criteria. I know that you're having suicidal symptoms. I know that you're filled with self-harm ideas, but you seem to be calm and rational. Therefore, we cannot keep you here. Call, go home, and here's the crisis number to please call. Why is it essential to have somewhere in between in between your house and the locked psychiatric crisis ward? Because mental health episodes don't come on all at once, and early intervention is less traumatizing than institutions. And ultimately, this builds the skill set and exposes the patient or the client to the peer network, which leads to natural networks of support. I wanted to submit some language amendments, particularly I would like to make an amendment to help structure one of these exclusively or particularly for the BIPOC community in the metro area. Thank you so much, Representative Sanchez and committee members, for your time. Again, Kevin Fitz, I'm a volunteer with the Oregon Mental Health Consumer Association. Thank you very much.
Thank you, Kevin. Jonathan Betlinski. I think I got that one right.
You did. Thank you, Chair Sanchez. I appreciate that. For the record, my name is, I should start this formally. Chair Sanchez and members of the committee, for the record, my name is Dr. Jonathan Betlinski, and I am an adult psychiatrist who currently serves as the Director of Public Psychiatry at OHSU. I'm here today to testify in support of House Bill 2980, which would provide funding to operate 3 6-person peer respite centers in Oregon. As you are no doubt aware, a peer respite center is a voluntary, short-term, overnight program that provides community-based, non-clinical crisis support to help individuals experiencing a mental health crisis find new understanding and ways to move forward. Peer respite centers operate 24 hours a day in a home-like environment and are staffed and operated by people who have lived experience with mental health challenges, trauma, and/or extreme states. In my testimony today, I'll review 3 of the reasons why I support peer respite. My first reason for supporting peer respite is partly personal. Our crisis mental health system in Oregon is, at best, strained. As an OHSU psychiatrist, I regularly have the privilege of being the weekend attending psychiatrist for the Adult Psychiatry Consult Service. It's not unusual for our service to be following several people whose physical health no longer requires them to be in the hospital, but who must nevertheless remain in the hospital awaiting an opening on an inpatient psychiatric unit. These kinds of delays increase both the cost and length of care. Because it provides an alternative to emergency room or inpatient treatment for some individuals experiencing mental health crises, peer respite can alleviate the strain on our crisis mental health system and open up treatment space for others in need. My second reason for supporting peer respite comes from the Substance Abuse and Mental Health Services Administration, SAMHSA, which considers peer-delivered services like peer respite to be evidence-based programs that can result in a variety of positive outcomes for participants. In 2009, a SAMHSA-funded analysis of over 1,800 participants from across this country by Campbell and colleagues found that participants offered consumer-operated services as an adjunct to their traditional mental health services showed significant gains in hope, self-efficacy, empowerment, goal attainment, and meaning of life in comparison to those who were offered traditional mental health services only. My third reason for supporting peer respite is simply that peer staff crisis respite programs save money. In 2018, Aboushari and colleagues published a study of nearly 2,200 individuals on Medicaid in New York, in which they demonstrated in the month of peer crisis respite use and the 11 subsequent months, Medicaid expenditures were on average $2,138 lower per Medicaid enrolled month, and there were 2.9 fewer hospitalizations than would have been expected in the absence of the intervention. In summary, peer respite programs are evidence-based support services that can expand the help available to Oregonians experiencing a mental health crisis, result in significant positive outcomes for participants, and save healthcare dollars. I support House Bill 2980, particularly if Oregon's peer respite programs will be well connected to the rest of our mental health system. I ask for your support also. Thank you.
Thank you. Janie Gullickson? Hopefully I got that right. Janie, there you are. Please remember to state your name for the record.
Oh, yes. Sorry about that. I forgot to unmute myself. Good morning, Chair Sanchez and members of the Behavioral Health Committee. I am, for the record, Janie Gullickson, a resident of Beaver Creek in Clackamas County and the Executive Director of the Mental Health and Addiction Association of Oregon. I'm also a person with the lived experience of mental health and addiction challenges, a diagnosis of severe mental illness, but I also enjoy a life of recovery from what I was originally told would be a lifetime of illness. I'm fortunate that I had the kind of support and services that believed recovery would be the outcome, not the exception. The lens I present my testimony today in support of House Bill 2980 is as a person who worked as a peer support specialist, and now I lead a peer-run mental health and addiction recovery organization. Many of the people we serve who experience mental health distress or crisis have nowhere to turn other than in medicalized environment, such as the state hospital, local hospital emergency departments, and yes, we even in Portland area have a behavioral health hospital, but sadly these are the only options. And as I am sure each member of the committee are aware, all of these options are expensive and focused on the most extreme instances. Too often, people who reach out for help are turned away for not being acute enough or in crisis enough. Where do they turn? Is the only way to get help is to wait for the crisis to become an emergency or worse? We need peer respite. You have heard amazing testimony regarding the efficacy of peer respite. Peer respite's time has come here in Oregon, and by supporting House Bill 2980, you will not only be filling a huge gap in services, you will be casting a vote that says, we, your constituents, matter, that crisis can just be considered an event, and that we can and do recover when given the right support at the right time. Thank you for your time today.
Thank you. Laura Rose. I'm not going to try to mangle your last name.
Thank you. Dear some committee members, my name is Laura Rose, and I live in Marion County.
I'm sorry, Laura, you're a little choppy in there. Wondering if you could, I mean, is that just me or are other people hearing that?
There's something called Hearing Room C that has a mic on. I don't know if that would help.
That's necessary, actually. So I'm going to turn off mine and hopefully you'll get better. If it remains a little choppy, you might consider turning off your video to see.
Sure. I think.
Okay, didn't hear half of that.
I didn't hear that either. Sorry.
So we may be having a little bandwidth issue. I'm going to...
I can hear now.
Okay, go for it. If you want to just speak a little bit louder, that'd be helpful, and remember to state your name for the record.
For the record, my name is Laura Rose Maceras. I live in Marion County. I'm here to testify in support of Pure Respite HB 2980. I too have lived experience as a survivor of trauma, domestic violence, and mental health challenges. I have served Oregon as a consultant, consumer, and family advocate, working with many of our state's peer-run organizations and peer-delivered services providers. Last March, I launched the Peer Galaxy calendar, which links hundreds of providers of peer support, recovery, and wellness activities with over 10,000 offerings monthly. I also serve on the Oregon Consumer Advisory Council, the Children's System Advisory Council, and the Oregon Alliance to Prevent Suicide, advising the Oregon Health Authority. As Kevin shared last January, the Oregon Consumer Advisory Council recommended the members of the council with the Oregon Health Authority and the Office of Consumer Activities worked closely on many aspects, itemizing cultural responsiveness by design, budget, staffing, environment, policy, and more for Peer Respite. Oregon communities, individuals, and families need an option between outpatient services and inpatient hospitalization. There is a body of research on the topic of Peer Respite showing the benefits, life save, cost savings, outcomes. PeerRespite.net is a great resource I want to share with you. It's a website by researchers at Live and Learn, and it features research, reports, resources, evaluation tools, instruments mentioned, program manuals, and a directory of programs in 14 other states. Thankfully, through the internet and sites like YouTube, webinars and video tours are readily available with executive directors, peers, and peer supporters speaking to the impact, operations, success factors, lessons learned, and strategies to overcome challenges, including how they're delivering peer respite during the pandemic. Very interesting. So peer respite, as defined, I want to say Oregon has a network of people with lived experience, peers, and peer-run organizations ready to work on this. The planning, rollout, and evaluation of peer respite would be good to have guided by an advisory group, including people of many different cultures and communities across Oregon, and key partners. We're available to talk further. Thank you.
Thank you. Sharon Kuhn, maybe?
Her last name is Keen, and she said she may or may not be available. She submitted testimony.
Good morning. Hi, my name is Sharon Keene, and I was able to be here. Thank you so much, Representative Sanchez and the Behavioral Health Committee. I am a resident of Milwaukee in Clackamas County, and I work as the manager of the David Romphrey Oregon Warm Line and also the Oregon Senior Peer Outreach. I have committed my life to peer support. I am a person who has experienced trauma and altered states or breakdowns that have had me hospitalized in the state hospital. I've lived a life of recovery and focusing on well-being, and I have found that the most healing aspect of my life is the connection with others who have experienced these types of difficulties, and how we share our experiences and how we come to know ourselves as valuable, contributing, intelligent members of the community. And so I'm very busy all the time running the Oregon Warm Line so that we can have peer support to anybody who picks up the telephone between 9 a.m. and 11 p.m. every day of the year. I am so enthusiastic about peer respite in Oregon. I cannot express strongly enough how much this is a particular application of peer support that is very, very helpful for where our system is right now. As others have said, when we're having difficulty, when a person is starting to not be able to live their regular life or do the things that they normally do, we need a support that allows us to enter a safe space where we are in connection, we're in a place where we're not causing devastation and destruction to others. We're being greeted as if we are valuable people. It doesn't require the kind of expensive medical treatment that is available in the hospital. 3.5 years ago, I went through a difficult cycle where I had lost my boyfriend, I had lost my housing, my job was at risk, and I was a wreck. I needed support. A friend of mine took me to the hospital, and I waited in the waiting room overnight, and they never accepted me. Somehow I didn't qualify for that support. If there had been a peer respite, that's where I would have gone. I want to tell you that I worked in California for almost 30 years. I helped with the development of a peer respite there called Second Story in Santa Cruz County. It's a peer-run service in a home-like setting. 7 years after helping to develop that resource of a peer respite in Santa Cruz, I myself fell into a difficult transition and ended up using that service to support me through a difficult time. It is a type of service is that my time up? I just want to say it's affordable, it saves money, it saves lives. It's time for us to do it now. Thank you so much.
Thank you, Sharon. And Casper. Anne, are you with us? Anne, Casper? I'm not seeing her.
Madam Chair, I don't see her on the list.
Yeah, Madam Chair, I don't see her in the participant list either.
Okay. We're going to go on then. If she happens to pop up, we'll catch her if we make it to the end here.
I'll try to monitor.
Thank you. R. Drake Eubank.
Hello, can you hear me?
Yes.
Thank you. My name is Drake Eubank. I am from Eugene, Oregon. I am a person that helps start what was the first agency that was peer-run in Oregon in 2001 that was able to bill Medicaid for what essentially were support services, community-based services provided both through a drop-in center and in the community. That is now morphed into, I and the people that started that were involved in the first certifications and trainings that are now training upwards of 1,500 to 2,000 people in the state to do actual work. I would like to speak to a couple of things. One is outcomes, and the other is the qualifications. You know, I get this perception sometimes when people are relying on using terms like lived experience and people that have been in the system. There's a lot of stigma that's attached to that, even now, even when we're trying to be egalitarian about our treatments of marginalized communities. But I would like to make the case for a superlative treatment rather than a derogatory treatment of these people's lives who work in the system. The skills they bring to their job are actually remarkable, and there isn't any university or college you can go to know what it's like to live in a home where you're being abused by an alcoholic parent, or you've experienced serious trauma and managed to recover from it. Those are tools and skills that are extraordinarily hard won and deserve some recognition beyond just simply the catchphrase that they have lived through it or they've had experience of being in the system. It's quite a different thing, actually. And it means a lot more than people give it credit for. Given that, the other thing I wanted to talk about is outcomes. Is the system a long time has been fairly complacent, and nobody has really demanded much of the system's results over time as much as they have allowed maintenance, mitigation, and lots and lots of requests for more and more money. Money being asked for this, I think, is pretty minimal. And I would like to make a case for letting it prove itself. And if it does, having some real support for it the next time you see it come up in the budgets. And I think peers, for the most part, and people working in the system that have been in the system at times would probably be totally willing to compete on results. And I think that's something worth paying attention to, because you have a huge system problem. You have a community, pardon me, all of your hospital exits, all the things put emphasis on community-based care, and guess what? You have no support system for them to exit to. The peer respite is just one component of things like that, but you really need a wider support network if you're going to actually get people out of these institutions that I think you're under federal guidelines to get out of right now. Thank you.
Thank you. That actually, Zoe, do we have anyone else who maybe signed up at the last minute?
Madam Chair, I don't have anyone else on my list.
Fabulous, thank you. Do folks have any additional questions for Representative Hayden? I thought you might. Representative Morgan.
Thank you, Chair Sanchez. And I guess my one question would be related to, first and foremost, I like this idea. I think we really need it. But is there a database of who qualifies or what the standard level is for a peer respite, a qualification process of clearing? Is there, as some of these are lifelong, there's times that the provider needs services themselves. And so is there a way to suspend temporarily while they're getting help needed, or that they come along getting help and support if they find themselves also needing help at that time, as a couple testifiers provided? Who's going to monitor the program, or who oversees that process?
Yeah, thank you, Rep. Morgan. This is Rep. Hayden. Thank you for the question. The Oregon Health Authority would be the one that monitors the program, and they have definitions of what peer support is and what peer respites is. When we talk about a peer support organization, we want that lived experience, which I think in this situation is a positive thing. And so it would be the Oregon Health Authority that organizes, we are going to have a couple amendments, that organizes this and then sends it out. You can look at this as a pilot project. I think we need these across, we need 36 of them or more, one in every county. But it's hard to get a program going. So this is kind of, the idea is a pilot project to start these programs, track it, and then see where your cost savings is. As far as eligibility of who would be able to access, we want that eligibility open as much as possible, but Oregon Health Authority would lay that.
Thank you. Other questions? Okay, well, let me just say, I actually appreciate this idea very much, and as Dwight Holton mentioned, it is definitely like the third leg of that stool that I believe we truly need to sort of really stabilize the mental health system here in Oregon. We know very well that hospitals are not the best place for folks to end up when they're in a mental health crisis, because there's often not enough room. And my apologies for the noise in my house here. We're doing construction. But we also know that, police are not the right response. So the expanded cahoots model is actually going to be very supportive of that. The 988 situation, where we're actually going to be able to hopefully move to a place where we can actually, create that much more broad spectrum of support for folks in mental health crises is just going to be so very, very important. So I'm really thankful for this bill and many others that are going to help to try to rebuild this system in a way that makes much more sense. So I'm going to close the public hearing on House Bill, where's the actual number, 2980. And we are actually done for the day, as far as I know, unless there's anything else, Zoe. Oh, reminder that for those who are listening, and that written testimony couldn't be submitted for any of the bills today until tomorrow morning at 8 a.m. Anything else, Zoe?
No, Madam Chair, that's everything.
Representative Solman, did I see your hand go up?
Yeah, Chair Sanchez, I just really wanted to make a comment to say thank you so much for your leadership in this arena. I think that pre-COVID, we all saw the mental health needs of our students in the Student Success Act across the state. And I think even more now in folks being in seclusion and dealing with so much, whether it's COVID or wildfires or what they're dealing with, and knowing that we're really pushing that message that mental health care is physical health care. It's the same. And I just really thank you for your leadership on this, and I'm very privileged to be part of this conversation.
Thank you. And again, thank you all for your support in this work and really looking at this from the perspective of, all Oregonians deserve amazing health care, and that, in fact, yes, the mental health aspect of this is vitally important to our physical health as well. So I am going to, end this committee. We are adjourned. Bye, folks.